on ultrasound, such as non-thalasseal, diaphragmatic hernia, major central nervous system abnormalities such as genesis de corpus callosum, cardiac abnormalities, skeletal dysplasias, and combinations of those are well described. But increasingly, and with improved time and expertise, more subtle fetal dysmorphology is increasingly diagnosed and is making up a contribution of babies that have multiple anomalies, such as subtle talipes, polydactyly, syndactyly, and hypotelorism, and micronathia. And these all have and feed into the potential for underlying genetic diagnosis. What we don't have in prenatal life is the ability to know whether a baby will have developmental delay in terms of its neurological development. And we don't have additional information that pediatricians have, such as information such as convulsions associated with the malformations. Certainly, skeletal dysplasias in terms of exome sequencing, prenatal exome sequencing, has been a fruitful vein for investigation, and mainly because the phenotype is often very striking on ultrasound, and it is often unequivocal that the baby has a severe skeletal dysplasia. But a cohort study by Lynn Chitty at Great Ormond Street indicated that a positive diagnosis of exome sequencing can be made in over 80% of cases, and that improves counselling and pregnancy management for parents. In terms of non-immune fetal hydrops, both our own data in the UK and around Europe, and also groups from the US, have published data on the association of pathologic variants with non-immune fetal hydrops, which is fluid on ultrasound in more than 2 body cavities associated with skin edema. There's some controversy perhaps within the classification of hydrops as to whether or not babies with large nuchal translucencies in the first trimester and then who subsequently develop skin edema or progressive effusions should be included in the classification. But looking at the literature, and again, this forest plot summarizes the literature to date, a meta-analysis indicated that in isolated non-immune fetal hydrops, there's a nearly 30% association with pathologic variants and monogenic disease. And if the hydropic fetus has additional structural abnormalities, for instance, like complex cardiac abnormalities, then the yield increases to nearly 40%. We wanted to look to see whether or not there was information in terms of whether or not babies with large nuchal translucencies in the first trimester would benefit from exome sequencing if autosomal trisomies were excluded. And we published these data at the end of last year in British Journal of O&G. And we combined our prospective data sets from the PAGE study with the Petresky study from Columbia University in New York. And we had 213 cases of babies that had large nuchal translucency, which was defined by greater than 4 millimeters in the first trimester. And of those, 54 were non-isolated. In other words, at the time of first trimester screening, additional abnormalities were noted on ultrasound. And in those cases, once there was investigation and testing, 1 in 5, 22%, had underlying pathologic abnormalities. But if the baby had an isolated nuchal translucency in the first trimester, then the risks of associated genetic disease would be dependent upon whether it remained isolated or not. So to look at these data in more detail, in those fetuses, there are nearly 159 that had a large nuchal translucency that was thought to be isolated in the first trimester. Of those 159, 37 of those developed additional features on rescanning, either at 16 or 20 weeks gestation. And in that group that developed further abnormalities, the association with genetic variants on exome sequencing was 32%. If it remained isolated, then the diagnostic variant rate was relatively low at 3.4%. So it really does depend on whether there are additional anomalies associated with a large nuclear translucency in the first trimester as to whether there is a high risk of genetic disease. When we looked at the evolving phenotype in babies with isolated large nuclear translucency, but then developed abnormalities in the second trimester, the majority of additional abnormalities, not surprisingly, were cardiac abnormalities. And of the diagnostic variants that were identified, over 50% of them were vasopathies. Some were associated with non-syndromic CHD, Kabuki syndrome, Charge syndrome, and Opitz syndrome. So there was a mixture of complex genetic disease, many of which were de novo. Fetal central nervous system abnormalities is another area where exome sequencing can be focused. And again, we published our prospective series in collaboration with the Columbia University group, this year in prenatal diagnosis. And in our cohort that we investigated, there were 268 fetuses that had structural abnormalities. And when, as a total group, they had association with monogenic disease identified by exome sequencing in 13.8% of cases. But when you actually drill down into those data, you can see that when there was multiple organs system involvement, so central nervous system and an additional abnormality outside the central nervous system, then pathologic variant rate was about 16%. When there was multiple different central nervous system abnormalities, then the pathologic variant rate increased to 19%, nearly 20%, so 1 in 5. And even when there was isolated central nervous system, and I'll break that down because one of the cases just had borderline ventricular megaly, then the pathologic variant rate was 7.2%. And when you look at the distribution of this in isolated abnormalities, you can see that several babies that had mild ventricular megaly had associated genetic variants, which is more than we would think. And also, you'll remember from the test directory, is different from focusing on major central nervous system abnormalities, and perhaps is worth further investigation in the future, because pathologic variants like these may well have an impact, and always do usually have an impact, on the long-term morbidity of babies delivered with what is thought to be a relatively benign disease. So finally, we looked at the data that Lynn Chitty's group produced in a systematic review published this year as to the clinical utility and detection rate of monogenic disease in babies per system to look at the percentage yield. And you can see within these forest plots that skeletal, neuromuscular, multisystems, hydrops, and central nervous systems, which are all in the test directory presently, have relatively high detection rates of monogenic disease. Cardiac disease is interesting, and I haven't got a lot of time to talk about that at the moment, but that falls on the 10% line. So 10% of babies with congenital heart disease may have underlying genetic disease, and there is more work to be done to break down the phenotypes of which may be the most fruitful babies to investigate. Obviously, exome sequencing could be applied to all babies with structural abnormalities, but one of the reasons for looking at data in this way is to try and find an equipoise balance for health economics, because presently this is quite expensive testing. In the UK NHS, this is free at the point of delivery. So parents don't pay for this, it's free. And so there is a health economic evaluation as to whether or not this should be offered in the baby that has congenital abnormality, and the 10% abnormalities that are on the 10% line are within the test directory and the chosen ones. Obviously, you can reduce that threshold and the health economic costs will increase, but the yield in those babies will also get lower. and is a fine balance. All of what I've mentioned today, though, has the potential for ethical and moral dilemmas for both parents and healthcare professionals going forward. And I, again, because of time constraints, can't discuss that in detail, but I would draw your attention to this very good review article that was published in Prenatal Diagnosis several years ago now by Ruth Horn and Michael Parker from Oxford, where it discusses the impact or potential impact of prenatal exome sequencing and next generation sequencing on healthcare in obstetrics. It is, though, likely going forward that transgenerational genetics will change our specialty out of all recognition. This is sort of the circle of life, if you like. Preconceptual investigation from preconceptual carrier status testing, pre-implantation testing by using pre-implantation genetic diagnosis and mitochondrial disease testing, again, have the ability to have a major impact used in the reproductive medicine sector. I've already mentioned prenatal diagnosis, which obviously is my field, but non-invasive prenatal testing and diagnosis, but exome sequencing are likely to improve detection and give more information to families going forward. But of course, postnatal testing is also very important. So we published data on babies that had an prenatally identified fetus with abnormalities where the parents chose termination of pregnancy or the baby was lost by stillbirth, where we went on to perform exome sequencing. And a significant number of babies, 30%, had pathologic variants. And within the NHS pathway, if parents choose that pathway, they're then eligible for, or the baby's eligible for a whole genome sequencing in the postnatal period. And that will have additional diagnoses, both of exonic and intronic variants, which will lead into further information for the pregnancy cycle going forward for future pregnancies. And then finally, I'm on the working party for Genomics England, looking at the implications for whole genome sequencing in newborn testing. In the UK at the present time, babies have a Hill prick on day 5 and 9 genetic diseases are tested for, which is relatively conservative compared to the rest of Europe and certainly worldwide. But whole genome sequencing has the power to look for many, many more potentially treatable underlying genetic diseases. And certainly there is a panel of 150 genes that we're investigating, and a pilot study is about to be launched in the UK so that with consent, babies can be tested from Hill pricks in early neonatal life, asymptomatic babies, and that information can potentially be fed back to parents. And again, that will have the impact of further in future pregnancies giving information that can be utilized for prenatal diagnosis. And of course, it will have an impact potentially for those children going through their life in adulthood, because these data will be linked to the NHS record. And so if a child develops unexplained disease at 8 years of age, their whole genome would have already been sequenced and could be accessed. So going forward, there's going to be a major impact in genomics, both in pregnancy, but also going through the whole road of life, if you like. So thank you very much for your attention. As I said, exome sequencing can have a significant impact in prenatal diagnosis. There is much work to do in terms of identifying the correct phenotype in utero of babies to focus this testing on. And I would finish by emphasizing that this isn't just laboratory testing. The whole of this pathway is focused upon multidisciplinary working. So fetal medicine subspecialists, geneticists, molecular scientists working together, pathologists working together to obtain a disease that identification that can be fed back to parents so that families have information going forward about their reproductive health. Thank you very much for your attention.
Xin cảm ơn phần trình bày bài giảng vô cùng cuốn hút của giáo sư McKinby. Các phần câu hỏi của các anh chị liên quan đến phần này, xin các anh chị đặt câu hỏi ạ.
I think already in your healthcare system, you are starting in very selected cases to apply exome sequencing.
So thank you for your presentation. And I have two questions for you. So the first one, can you tell me the differences about sensitivity, specificity, and accuracy between the microarray and the CNV generated by NGS? And can NGS replace completely by microarray? The second question is that, so in case of VUS variant, so what is your recommendation in counseling for the patient? And I want to ask more question that in your presentation, you told that in a research from UK, they have a research concluded that more than 1,300 genes related to intellectual delay. So in the case of isolated intellectual delay, so what is the approach, and which genetic testing is the first higher? Which you use whole exome sequencing, whole genome sequencing, or clinical diagnostic testing with more than 4,000 genes? Thank you very much.
So that's a lot of quite complicated questions. In the UK, microarray testing is by platforms that are not whole genome sequencing based. I know data from Hong Kong indicate that they feel more comfortable in using whole genome sequencing, but for we use SNP analysis, so the platforms utilized commonly in babies that have structural abnormalities are SNP-based platforms that have resolution down to the 1 kilobase there. So you still may miss some rare like copy number variants, but the majority are picked up. The number of studies that actually look at sensitivity and specificity are relatively small, both in the UK and worldwide. But I think everyone is agreed that microarray testing prenatally in babies that have structural abnormalities is certainly worthwhile. I think the controversy now is if you screen positive on first trimester combined screening and you have an amniocentesis, for instance, at the present time in the UK, you just have QF-PCR testing, so they exclude autosomal trisomies and monosomy X. We've already said that 16% of chromosome abnormalities can be subtle rearrangements or deletions, and there are different health economies around the world. For instance, in Denmark, they perform microarray testing in that group as well, whereas we don't do that in the UK. So you can detect babies that have potential morbid associations. So that's the answer to your first question. I think and how they influence practice, I think they can be very difficult. And I think that, as you quite rightly emphasized, the prenatal testing in the UK is not whole genome sequencing. It's not whole exome sequencing. It's a clinical exome panel. So it's a panel of 1,200 genes approximately that have been associated with pathologic variants that can cause disease in utero. And so the VU association is relatively small in that group. The problem we face is that sometimes variants can be identified, but the phenotype that we utilize on ultrasound doesn't match. So a good example of that is Kabuki syndrome. So Kabuki syndrome for pediatricians and geneticists, babies are very short stature, mental retardation, classical dysmorphic features, often with very prominent eyebrows and very prominent classical faces. Now, obviously, in utero, you can't see those things. Many of the babies are small for gestational age, but that isn't an indication for testing alone. And looking at the phenotypes for variants that represent differently in the prenatal period is very important. So with Kabuki syndrome, many babies have non-immune fetal hydrops and cardiac abnormalities. So increasingly, there's been a call for repositories to document the fetal phenotype so associated with variants so that you hopefully can match them and say that they're causative rather than being classified as class 3 variants and therefore potentially VUs. And that will help. So journals such as Prenatal Diagnosis have started a repository for case studies. The Fetal Medicine Foundation also has an online facility to record those kind of data as well so that people can look up and see whether that's been reported before. To answer directly, though, your question, I suppose VUs are filtered out in two ways, one of which they may not be reported. So in other words, the laboratory will say, well, this looks like it's a class 3 variant. It doesn't match the phenotype. We have a multidisciplinary discussion and we're deciding not to report it. So that's one way. And the other way is for postnatal counseling, post-test counseling between fetal medicine subspecialists and geneticists to emphasize that this variant has been found, but it doesn't explain the underlying variant, which is, of course, difficult, but sometimes these difficult conversations have to take place and is one of the downsides of testing.
Anh chị nào trong hội trường có đặt câu hỏi đề nghị giơ tay để ban tổ chức chuyển mic tới ạ. Anh chị nào tham gia online có câu hỏi thì để trên hộp chat ạ.
Trước hết là cảm ơn bài báo cáo của thầy rất là hay. Nhưng cũng rất là sâu. Thực tế thì vấn đề về di truyền thì thực tế thì mình cũng chưa có nắm hết được nhiều đâu. Anh em mình những là những nhà lâm sàng thì cũng không nắm hết nhiều trong vấn đề di truyền. Thì mình có hai cái câu hỏi mà hai câu hỏi thì cũng chắc là thực tế thôi, từ những người làm trong lâm sàng thôi. Thì hiện nay phải nói là cái ngành tiền sản mình nó tiến bộ được trên thế giới cũng như ở Việt Nam những năm gần đây là phải nói là về công nghệ di truyền. Để không có công nghệ di truyền thì chúng ta sẽ đứng lại một chỗ và chúng ta rất không biết là cái chẩn đoán nó đi thì như thế nào. Và ngay cả cái công nghệ di truyền hiện nay rất tiến bộ thì cũng có rất nhiều bệnh mình không chẩn đoán được. Thì hiện nay về hồi nãy như cái bài báo cáo của thầy đề cập đến những vấn đề rất là cập nhật với những bệnh lý thì chẩn đoán là rhizopathy hoặc là ciliopathy hoặc là những bệnh lý về metabolic disorder. Thì là có cái định hướng nào về lâm sàng hoặc là lâm sàng để mình có thể hướng những bệnh lý này theo cái hướng là rhizopathy, ciliopathy và metabolic disorder hay không? Và điều này nó có thực tế với cái gì về mặt lâm sàng đó. Một câu hỏi thứ hai là liên quan tới vấn đề thực sự. Hiện nay thì các labo không biết ở nơi các nước của các thầy như thế nào, nhưng mà labo ở Việt Nam hiện nay một số labo là ngoài cái việc đề nghị làm NIPT đó, đúng hơn là NIDS screening đó, thì là người ta đề cập rồi những vấn đề xét nghiệm với rất thể cái bệnh lý mà hay gặp, ví dụ như là bệnh 13, 14, 18, 21, XY, vân vân. Thì họ đề nghị làm thêm những cái xét nghiệm có vẻ hình như là 25 bệnh hiếm đó, monocystium 25 bệnh hiếm, ví dụ như bệnh lý ví dụ như là về loạn sản xương sụn, achondrodysplasia, hoặc là bệnh lý về Noonan, hoặc là bệnh lý thalassemia, vân vân. thậm chí họ cũng đề nghị làm thêm nữa trong quá trình mà lấy máu làm IIPT đó, thì là mình kiểm tra luôn máu của người mẹ đó, nó có mang những bệnh lý hiếm không. Bệnh lý là nó rất nặng, ví dụ như bệnh là rối loạn chuyển hóa đồng, bệnh Wilson chẳng hạn, hoặc là bệnh Pepon chẳng hạn. Thì là theo ý các thầy thì cái vấn đề đó là cái vấn đề phải là cái thực tế nó là hiện tại, hay là chỉ vấn đề tương lai, hay là những vấn đề chỉ mang lại một lợi ích cho một nhóm lợi của labo hay không. Tại vì những cái xét nghiệm này á, những cái bệnh lý mà trisomy 18, 13, 20 là những bệnh lý nó đặc殊, bệnh lý nó khác nhau. Nhưng mà những bệnh lý hiếm đó ở ví dụ như bệnh lý về gen, những bệnh lý về hormone, những bệnh lý về hiếm quy sinh thì cái tần suất lưu hành bệnh nó rất thấp. Và như vậy thì khi mà làm xét nghiệm như vậy mình vô tình đưa vô một cái chỗ rối cho các bà mẹ. Có thể đưa đến những việc chẩn đoán xâm lấn, ví dụ như là test xâm lấn, ví dụ như cặp ấu chẳng hạn, hay là làm CBS chẳng hạn. Bởi vì cái tỷ lệ dương tính giả của nó là quá cao. Thì trở lại vấn đề câu hỏi là như vậy thì cái thực tế thì cái test này có thiết thực hay không, hay là nó chỉ là lợi ích của labo. Cảm ơn các thầy.
Okay, again, very multiple and complex questions. I think firstly, to emphasize that you're never going to diagnose every genetic abnormality prenatally on a baby because the phenotype is limited, as I've indicated, and we don't have information that pediatricians have at their fingertips, which is the benefit of being able to look directly at a baby and clinically examine it. And also the benefit of seeing how a baby and child develops as they grow. So we'll never have necessarily all of that information. Also, exome sequencing will miss intronic missense variants, which can be quite profound sometimes. And so at the moment, exome sequencing is used in prenatal diagnosis, not whole genome sequencing, but that may well change going forward, increasing the diagnostic yield. I think it's also important, and it's important to understand what's happened in pediatric populations where this genetic diagnosis testing has been utilized, is that the panel that is utilized, or the tests that have utilized, the genes that are looked for, is often modified over time. So if a child tests negative and you can't find a cause in 2020, it may be that the baby needs to be tested further going forward to see, and in a proportion, perhaps up to 5%, you eventually make a diagnosis because the panel picks up the gene. So you won't always make the diagnosis at the first time. In terms of the impact of ciliapathies and resopathies, they're serious genetic disease, often associated with structural abnormalities, and they can be significantly morbid. And therefore, in the UK, that additional information often, not always, but often feeds into parents making choices in terms of termination of pregnancy, but not always. In terms of non-invasive testing or non-invasive screening and non-invasive testing, I think the role of screening for autosomal trisomies and monosomal X is relatively well tested and explained. I think there is a need, though, to confirm the diagnosis with invasive testing, amniocentesis, because as I've indicated, especially in trisomy 13, 18, and monosomy X, you may get confined placental mosaicisms, which can be. So it's important to do that. In terms of increasing private laboratories offering other non-invasive screening for microdeletions, I think the data is very limited in the published data, I mean, in terms of clinical utilization of that. And I think a lot more work needs to be done because what is true of caveats of false positivity and negativity for Downs, Edwards, and Patter's is doubly true for subtle microscopic chromosome problems. So presently, I don't think they should be offered in non-invasive prenatal screening. In terms of genetic disease and non-invasive diagnosis, certainly for certain genes, it's possible to do that for targeted single gene abnormalities. It's not really positive to do that in autosomal recessive disease because of problems of carrier status for the mother. But going forward, that obviously is, if you like, the holy grail in terms of exome sequencing, to be able to offer prenatal, non-invasive prenatal screening, stroke diagnosis. But I think we're a very long way from that at the present time. And the depth of sequencing and the exclusion of the contribution for parental carrier status has a lot of work to be done before that can be introduced into clinical practice. Thank you.
Em xin cảm ơn bài giảng rất là lý thú của thầy. Em có hai câu hỏi thôi ạ. Câu hỏi thứ nhất là liệu có các cái đặc điểm gì trên siêu âm để chúng ta tư vấn cho bệnh nhân thực hiện một cái xét nghiệm mức độ CNV, tức là copy number và variant, hay là chúng ta làm cái West, tức là whole exome sequencing. Như vậy có cái đặc điểm gì trên siêu âm để giúp chúng ta tư vấn cho bệnh nhân làm cả cái xét nghiệm đấy không? Bởi vì cái giá thành của hai cái xét nghiệm nó khác nhau hoàn toàn. Câu hỏi thứ hai nó liên quan tới cái thể khảm. Một số trường hợp khi chúng ta siêu âm thì chúng ta thấy có bất thường ở giai đoạn sớm. Sau đấy chúng ta thực hiện cái sinh thiết gây nhau CVS. Thế thì khi cái kết quả của sinh thiết gây nhau nó tạo ra cho chúng ta là thể khảm. Đấy. Vậy thì chúng ta có chờ đến 16 tuần chúng ta chọc ối và chúng ta khẳng định em bé đấy bị thể khảm hay không? Xin cảm ơn giáo sư.
I think if you're talking about mosaicism, you're talking about non-invasive prenatal screening. If there is thought to be a mosaic result from non-invasive prenatal testing, then I think it depends a little bit on whether the baby has structural abnormalities at the time of testing. But for the most part, from a genetic testing, you would be wise to wait for a result from an amniocentesis test to confirm the baby actually has the abnormalities. But of course, the chance of that happening are greater in a baby that has no abnormalities that's identified and it's picked up incidentally on the non-invasive prenatal screening. In those cases, it's more likely that there'll be placental mosaicism. Whereas if a baby has structural abnormalities, then it's less likely. I think during my talk, I outlined the phenotypes that allow or are focused upon for prenatal exome sequencing and the whole genome sequencing. So I don't really think I can go into any more detail about that. I think obviously it's imperfect, and as we screen babies more and more looking for structural abnormalities and as resolution of ultrasound gets better and we use other adjuvant imaging techniques such as MRI, there may be more information that feeds into the phenotype. But until that happens, I think we need to be conservative about offering this powerful genetic diagnostic technology in pregnancy, because if you haven't got clearly defined criteria to utilize it, then you'll end up not being able to explain to parents any results. Thank you very much.
Các câu hỏi sẽ được tiếp tục sau phần trình bày của bác sĩ Marianne Le Gouvin. Tiếp theo là phần trình bày của giáo sư của bác sĩ Marianne Le Gouvin. Is the presentation of Miss Marianne Le Gouvin, please.
Sorry.
Chúng tôi xin trân trọng giới thiệu tiến sĩ Marianne Le Gouvin, giảng viên chuyên gia về y học bào thai đến từ bệnh viện Nickel-Onfort-Mallet và trường đại học Vuane de Carter. Tiến sĩ Marianne Le Gouvin là chuyên gia về virus học tại Pháp. Bà từng có thời gian công tác tại rất nhiều bệnh viện và trung tâm lớn như Bệnh viện Avicenne, Đại học Paris 13, Bệnh viện St. George's, London. Hiện tại, bà là cố vấn chuyên khoa virus học tại Bệnh viện Nickel-Onfort-Mallet, Đại học Vuane de Carter. Bà có rất nhiều đóng góp trong hoạt động nghiên cứu tập trung vào dịch tễ học lâm sàng, chẩn đoán và điều trị nhiễm trùng bẩm sinh CMV. Tại khóa đào tạo lần này, tiến sĩ Marianne Le Gouvin sẽ chia sẻ kiến thức và giảng dạy xoay quanh hai chủ đề: huyết thanh mẹ và kỹ thuật PCR cho nhiễm trùng bào thai, điều trị thai nhi.
Thank you. Okay. Thank you. So I'll talk about the interpretation of maternal serology. So congenital infections are mainly due to viruses. Among them, the most frequent are Rubella virus, CMV, parvovirus, B19, and Zika virus, which is missing there. And other microorganisms can be responsible for congenital infection like toxoplasmosis, syphilis. Perinatal infections are also often due to viruses, mainly HBV and HIV, of course, and perinatal sepsis are due to bacterial infection. In this talk, I will focus on the serology in congenital infection due to viruses. So the indication of serology for congenital viral infections may be systematic screening in pregnancy, diagnosis for different maternal reasons, mainly contact with the virus or maternal compatible symptoms, or the diagnosis may be linked, maybe due, maybe in the context of compatible fetal symptoms. So systematic screening in pregnancy, we do that for rubella, and hopefully in the near future, maybe for CMV. Systematic screening of rubella serology during pregnancy is mandatory in most industrialized countries. We do that at the first prenatal visit. We measured only IgG, IgM are not done. And the objective of this screening is to identify unprotected pregnant women in order to vaccinate them after delivery and to protect their future pregnancy from congenital rubella. We've done rubella serology for decades now, and still the interpretation of rubella serology results are not always easy. And this is due to the lack of standardizations of rubella IgG commercial assay.
because although rubella IgG titers are expressed in international units per ml, the standardization of results is not effective. You see here the result of more than 300 samples that had been tested with 8 different commercial assays. And you see here, I suppose, yes. You see here, for example, with this here, commercial assay, the mean value of IgG, rubella IgG in international units per ml is around 60. When with this other technique here, you see that it's more than 100. So these differences in rubella IgG commercial assay are due to different antigens that are used by this assay, either total virus, recombinant proteins, different formats in the assay, indirect sandwich competition or capture. Knowing that the new generation assay are more sensitive and give higher titers than the previous assays. This is complicated because it can lead to different interpretations for the same sample, mainly for sera with low amount of antibody, that these samples can be immune with one technique and non-immune with another technique. And this means that sequential sera from the same patients must be tested with the same assay. Commercial rubella IgG assay are using a 10 international unit per ml as the cutoff for immune, non-immune. This cutoff is probably too high in countries with high vaccine coverage. And this cutoff was estimated to be 10 international unit per ml in the early 19s, at a time when wild-type rubella virus was still circulating in populations, offering natural boosters to vaccinated people. But now in the present time, in countries with high vaccine coverage, most of European countries, for example, rubella virus does not circulate anymore, and 10 to 30% of correctly protected individuals, people who had the 2 vaccinations, have antibodies less than 10 international units per ml. You see here, for example, in Finland, in this study in Finland, all individuals vaccinated with 2 doses of vaccine at rubella IgG over 10 international units per ml 6 months after the second dose. But 24 of those people had levels below 10 international units per ml 20 years later. But when they tested the IgG were at high avidity, indicating the presence of protective antibodies. And in France, among nearly 200 pregnant women with IgG less than 10 international units per ml in prenatal screening, more than 60 of them had specific anti-E1 antibodies identified by immunoblot and high IgG avidity, also indicating that these women had protective antibodies. So probably we need to establish a new lower cutoff value to improve the correlation between the true immune status of the pregnant woman, the vaccinated pregnant woman. So this can lead to misinterpretation of results for women with low-level antibodies, those who have antibodies around the cutoff, and may lead to wrong clinical managements, unnecessary revaccinations, and observations of seroconversion not due to a rubella primary infection. And as an example, this is a little clinical case. a pregnant lady, 6 weeks of gestation, she has first serology done in a first laboratory using rubella IgG architects from Abbott. And the result was 9 international units per ml. And the conclusions of the serology was absence of protective rubella IgG, non-immune. This lady was retested at 18 weeks of gestations in a second laboratory using another technique that was the IgG from glycerin, and the result, the second samples was 20 international units per ml. Conclusion, presence of specific rubella IgG immune. So is this a true seroconversion, a true primary infection? To answer that question, we need to test both serum samples in the same laboratory with the same assay. That's what we did. And you can see here that the IgG level titers were stable with both assays. There were no seroconversion, no IgM. We tested the IgM also, no IgM. So the different results were due to differences in the sensitivity of the two assays, and not, it was not a seroconversion, it was not a primary infection. Now, what about CMV serology screening during pregnancy? To my knowledge, it is recommending only in very few countries, mainly in Germany and in Italy now. And if you do this screening has to be done in the first trimester of pregnancy at the first prenatal visit. This screening will rely on testing both IgG and IgM and doing IgG avidity if both IgG and IgM are positive. And the objective of this screening is to implement valacyclovir treatment for prevention and fetal transmission in women with proven primary infection. And Valentin will later explain all this. So who is concerned by this screening? Only population of pregnant women with a low seroprevalence of CMV, of course. Low seroprevalence means less than 60 to 70% seroprevalence in this population. This slide is to remind you that fetal CMV infection may be due to 3 different types of maternal infections, either a primary infection, but also a reinfection with a new strain, or a reactivation of the endogenous strain. So the fetus can be infected after a primary infection or after what we call a non-primary infection. And this is very unique to CMV because you know that a fetus can be infected by rubella, by Zika virus, by toxoplasmosis only when the woman has a primary infection. But for CMV, the fetus can be infected either after a primary or a non-primary infection. Of course, the burden of congenital infections following primary maternal infection versus non-primary maternal infection varies with the seroprevalence rate in the pregnant woman population. In countries where CMV seroprevalence in pregnant women is low, less than 60 to 70%, which is most of the European countries, for example, around half congenital CMV infection are due to maternal primary infection. And report here the result of a screening study we did in France a few years ago. We screened around 12,000 newborns. The prevalence of congenital CMV was 0.5%, and 22% of those cases followed the maternal primary infections, while 48% of those cases were due to a maternal non-primary infection. But in countries where CMV seroprevalence is high in pregnant women, over 90%, which is probably the case in Vietnam, although I don't know if the seroprevalence in Vietnam is known yet. 90% of congenital CMV infection, or nearly 100%, are due to maternal non-primary infections. And as an example, I've quoted here a study by a Brazilian group where they screen newborns. They found a prevalence of congenital CMV of 0.5%. And 10% of those cases were due to a maternal primary infection, while 90%, of course, were due to a maternal non-primary infections. So typically in this population with high seroprevalence, screening for primary infection by serology is not worthwhile. Serology for congenital infection may be done because of maternal reasons, such as maternal compatible symptoms. And a maculopapular rash in a pregnant woman should raise the suspicion of a primary viral infection that could be due to rubella virus, to parvovirus B19, or to Zika virus. It's difficult to tell the etiology of the rash because they are quite similar, actually. And knowing that the primary infection with these three viruses might be completely asymptomatic in about 20 to 30% of person. CMV gives non-specific, either the primary infection or the non-primary infection give non-specific symptoms, flu-like symptoms, and they cannot be easily diagnosed clinically. So the easiest way to diagnose a primary infection is through seroconversion. That will be pregnant women with first sera with negative IgG and following sera, subsequent sera with positive IgG. But that is not so easy. I've been talking already about the misinterpretation of serology results in women with low IgG titers, for rubella, for example. Also, for Zika virus, the IgG that are tested, that are measured by commercial assay, may show cross-reactivity with IgG against other flavivirus, dengue IgG mainly. So we have to do seroneutralization and cell culture to confirm the IgG specificity. And this is a complicated, very complicated method that is only done in specialized reference laboratory. In the absence of a previous sera, diagnosis of primary infection will rely on IgG plus IgM testing. So IgG and IgM are negative. This excludes a recent primary infection, except in cases of very early infection. For example, a sample collected early after a rash onset, 3 to 5 days, can be IgM negative. Then a second sample should be collected 5 to 7 days after the onset of the rash to be sure that it's not a primary infection. When the IgG are positive and the IgM are negative, this excludes a recent infection. We know that, for example, rubella IgM usually persists for around 2 months, and while CMV IgM persists for more than 3 months in 95% of cases. IgG negative plus IgM positive can be a primary infection, but you need to test a subsequent sera to see the seroconversion. And IgG positive plus IgM positive also may be a recent infection, but not always. because as you know, the presence of IgM can be the sign of a primary infection, but IgM may be prolonged for months. For example, for CMV and toxo, the IgM can last for months, sometimes years after the primary infections. IgM can be the result of vaccination. That's the case for rubella. When you vaccinate with the rubella vaccine, you have IgM. And IgM may be related to a non-specific stimulation of the immune system or a cross-reaction in case of another ongoing infection. For example, there are cross-reaction between IgM against Zika, IgM against dengue virus, cross-reaction possible against rubella IgM, rubella and B19 IgM, cross-reaction between CMV IgM and EBV IgM. So in case of a positive IgM, confirmation of a recent primary infection relies on dating the infection by testing IgG avidity. So IgG avidity is the average binding strength of an antibody population towards an antigen. Low IgG antibodies appear within 2 to 3 weeks after a primary infection or an immunization. And reflecting the B cell maturations, IgG avidity increases during several months to reach a plateau, and subsequently, including reinfections and reactivation, the avidity remain high. So most IgG avidity assay use a chaotropic protein denaturant, which is usually urea, to disrupt the antigen-antibody bond. And the results are expressed by comparison of antibody data obtained with and without the denaturant. Interpretation of avidity result depends on the microorganism. So for rubella, low avidity indicates recent primary infections, 1 to 2 months. High avidity does not well differentiate between a primary infection dating from 2 to 2 months or a past infection. For CMV, low avidity indicates recent primary infection, less than 3 months, and high avidity excludes a primary infection in the last 3 months. So toxoplasmosis, a high avidity excludes a recent infection, less than 2 months, and a low avidity does not always indicate a recent infection. So difficulties remain in the interpretation of avidity results. Interpretations of intermediate avidity values, the result that are neither low nor high, is difficult. And in those cases, dating of primary infections during or before pregnancy is usually impossible. Another problem is to do avidity when the IgG value are low. It's difficult, the interpretation is difficult, and sometimes it's impossible to give a result. And it must be stressed that commercial avidity assays have pitfalls, and it's important to select the best assay available. And it would be very useful to have an avidity test for Zika, IgG for avidity for Zika, but there is only one commercial test available, and this test does not show good performance. For rubella, only manual avidity assay available, to my knowledge, at best. And for CMV and toxoplasmosis, avidity assay can be performed now on high throughput automated platforms, which give good correlation between assay. a small clinical case. You have here a pregnant woman, 8 weeks of gestation with a rash. At 10 weeks, the rubella IgG was positive and the rubella IgM were positive. Is this a primary infection? We need to do the IgG avidity to be sure that it's a primary infection. And that's what we did. We did an rubella IgG avidity with an in-house test. And you see here that the result was low IgG avidity, confirming the primary infection in the first trimester of pregnancy. And the last situation when you can have to do serology for congenital viral infection is when you have compatible fetal symptoms at ultrasound. Fetal symptoms of congenital viral infection are usually seen after mid-second trimester. And at that stage, only a negative IgG result can exclude a maternal primary infection in the first trimester. Since IgM may have already disappeared at that stage, and IgG avidity might be already high. And this clinical case to illustrate this, a woman we've seen at 22 weeks gestation with ultrasound abnormalities, fetal brain ventriculomegaly and hepatomegaly. The same serology was done at 23 weeks. Positive IgG, IgM considered as negative in the gray zone of the technique. High avidity, IgG avidity with both technique we're using. But clearly, this does not exclude a primary infection in the first trimester, as I've just said. So the CMV serology was done on the stored sera collected at 10 weeks. And you see here that the IgG were low, the IgM were extremely high, and the avidity, IgG avidity were low with the above technique, confirming the primary infection in the first trimester. And I want also to emphasize that women with pre-existing CMV immunity may transmit the virus to their fetus, as we've said before, after a non-primary infection. But in those cases, serology is not useful to identify these women and should not be done. Indeed, serology cannot identify pre-immune women at risk of transmitting CMV to the fetus. In different studies, we reported that IgM are not sensitive enough. Only 13% of women with pre-existing immunity and an infected fetus had positive IgM during their pregnancy. And if you look at kinetics of IgG levels during pregnancy, it's not helpful. The IgG titers remain stable all the time, and IgG avidity remain high. And this is an example of a non-primary infection with fetal transmission in a pregnant woman. This woman was known as seropositive in her first pregnancy. You see here the results. She was IgG positive, IgM negative. And then her husband was diagnosed with a primary CMV infection. 3 weeks after the diagnosis in the symptoms in the husband, this woman was tested for CMV PCR in blood and urine, and it was negative. She was retested 8 weeks later, and the CMV PCR in blood was positive that time. It was still negative in the urine. And she was retested again at 9 weeks, and the CMV PCR was positive in blood and in the urine. demonstrating a reinfection in that woman. But you can see the serology here, it didn't change at all. The IgG were positive, the IgM were negative, and the avidity index was high. So serology doesn't show anything. So you should not do serology, CMV serology in a woman known seropositive. It doesn't help. So in conclusion, maternal serology interpretations remain difficult in some cases. You should be aware of the difficulty of interpreting serology with low IgG titers, with the problem of the false seroconversion. You should be careful in the interpretations of positive IgM, which are quite often non-specific. And you should try to get IgG avidity testing when IgM are positive. I don't know if it's possible here in Vietnam to get IgG avidity, but it might be something worth implementing in your lab. Wow, I'm ready for your question.
Xin trân trọng cảm ơn phần trình bày rất lý thú của bác sĩ Marianne Legouvin. Về vấn đề nhiễm virus bào thai, xin trân trọng kính mời các anh chị học viên đặt câu hỏi ạ.
Đầu tiên là em xin gửi lời cảm ơn đến thầy cô. Câu hỏi của em là do chứng nhiễm CMV nó không đặc hiệu ạ, thì những cái thai phụ như thế nào hay là những gia đình như thế nào thì người ta ở cái nhóm có nguy cơ phơi nhiễm?
I think the question is when should you screen? When should you do a CMV serology? Because the clinical, sorry. Yeah. But you can't say you can't say that's the problem. I think in the so okay, and the thing is that either you screen for CMV, and that's worthwhile in countries with low seroprevalence, like European countries, for example. Either you don't do CMV serology, I think, because you know that in countries like Vietnam, I suppose the seroprevalence is very high. So you know that this lady is going to be CMV positive. So the serology is not going to bring anything. And if you have suspicion that the fetus, for example, is infected by CMV, it's better to go to the prenatal diagnosis to check if the baby is infected or not. Serology is not going to help for CMV, I mean.
Một lần nữa xin cảm ơn cô đã các bài trình bày về nhiễm trùng bào thai rất là hay, một vấn đề cũng rất là thời sự. Thì mình có hai cái ca lâm sàng và cũng xin hỏi ý kiến của cô, kinh nghiệm của cô cũng như các thầy đến từ châu Âu. Tức là hai ca trường hợp này đều liên quan tới nhiễm trùng CMV. Một ca là nhiễm trùng trước sinh và một ca là nhiễm trùng chu sinh. Thì một ca mình bắt đầu bằng ca nhiễm trùng chu sinh, nhiễm trùng trước sinh, xin lỗi. Thì cái ca này là bệnh nhân đến rồi có thai quản thai kỳ thứ hai, thì là phát hiện là gan to, lách to và thiếu máu. Thì như cô đã trình bày thì ở Việt Nam mình thì phải nói mà làm gần như 20 năm thì mình thấy bệnh nhân nào tới xét nghiệm thai nó cũng CMV, IgG cũng như tới đây. Chỉ có một cái cô là Việt kiều, cô trở về từ nước Pháp thì là IgG nó âm tính. Cho nên có lẽ là đặt vấn đề là lâu đi mình vẫn là hay làm sàng lọc cái tột cho phụ nữ có thai Việt Nam, thì có lẽ mình bỏ cái xét nghiệm GMV vì nó quá tốn tiền. Thì cái trường hợp bệnh nhân này thì là bệnh nhân sau khi mà gan to thì trước đó lúc 12 tuần thì hình ảnh là được làm ở bệnh viện Tiền Sản, thì là hình ảnh MT nhưng rất là đẹp, cho nên mình nghĩ tới ngay một cái nhiễm trùng bào thai. Và bệnh nhân này được gửi vào trung tâm chào đón Tiền Sản cho bác sĩ Thu Hương tại thành phố Hồ Chí Minh để làm xét nghiệm cặp ối cũng như là về quyết định vấn đề điều trị. Thì là sau khi xét nghiệm thì là nó có CMV này, IgG và IgM dương tính. Bác sĩ thì rất hài lòng nhưng bệnh nhân thì không hài lòng. Vì hài lòng với chẩn đoán của mình nhưng bệnh nhân thì rất là buồn. Thì là mình đặt câu hỏi ở đây là mình muốn nói là như vậy, thì cái chẩn đoán khi bệnh nhân bị nhiễm trùng CMV trong bào thai ở cái thời điểm mà mình đã có chuyển lâm sàng rồi á, thì liệu vấn đề điều trị có còn có ý nghĩa hay không? Rồi, câu hỏi thứ hai là một bệnh nhân cũng nhiễm trùng CMV mà liên quan tới chu sinh. Thì bệnh nhân này là cái thai kỳ kiểm tra thì có một nơi cơ sở chẩn đoán cũng tương đối là ổn, thì là quá trình thi ở thai thì ổn. Nhưng mà khi mà em bé được 1 tháng tuổi nó bị sốt. Thì khi sốt đó mình làm xét nghiệm IgG và IgM của CMV thì nó dương tính cả hai luôn. Đồng thời lâm sàng kèm theo là bệnh nhân bắt đầu có vàng da và vàng da tăng dần lên. Thì không biết cái vàng da này nó bắt đầu từ lúc sau sinh hay là ở cái thời điểm nào cụ thể thì không rõ thời gian dần. Thì mình câu hỏi muốn đặt tiếp cho cô hỏi thêm là như vậy thì liệu kinh nghiệm của cô về nhiễm trùng CMV chu sinh có thể gây đến teo đường bọc bẩm sinh hay không? Bệnh nhân này sau đó được mổ tại bệnh viện Nhi đồng thành phố Hồ Chí Minh và chẩn đoán xác định sau đó là teo đường bọc bẩm sinh, không có xơ ngang, teo đường bẩm sinh ngoài ngang và nghi ngờ do CMV chu sinh. Thì muốn hỏi thêm các thầy các cô về kinh nghiệm việc điều trị của CMV trước sinh kèm theo triệu chứng và một trường hợp nhiễm trùng CMV chu sinh liệu có thể gây teo đường bọc bẩm sinh hay không? Cảm ơn.
Okay. So the first question, yes, you're right. If you have in your patients women who have been raised abroad and in countries with low seroprevalence of CMV, it makes sense to screen for CMV in those women. I agree. And the case you explained was very typical of congenital CMV in the fetus, fetal infection. So yes, I think it's interesting in that kind of this group of women to test for CMV. For the second clinical case you were mentioning, I think that infection, postnatal infection, can be extremely early in a baby, because the baby can contaminate himself very early through when at delivery through the genital secretion of the mother, and or by breastfeeding, because you have CMV in the breast milk. So it's probably more a postnatal infection, and which is extremely frequent and early, and it might not explain that. It might not explain all the symptoms you've seen in that baby. It's probably a coincidence because it's so frequent to have an early infections. And we have that a lot in France, because we test more and more for CMV in neonatal units, and we diagnose CMV through CMV PCR in the urine and the saliva, and we wonder if it's congenital infection or if it's postnatal infections. It's usually postnatal infections, and it's just because it's very frequent to have a early postnatal infection. So I would say that CMV was not responsible for all the symptoms of that baby.
And for the first question, should you treat the fetus with CMV one time the baby, the fetus already presented the symptom?
Yes.
Yes, yes or no, or you, is efficacy or efficiency or not?
I'll tell you with the next talk, but yes, I would have treated that baby with valacyclovir, yes.
Xin mời anh Sơn ạ.
Em có hai câu hỏi thôi ạ. Một câu là liên quan bài giảng của cô và một câu là liên quan nhiễm trùng bào thai. Thưa cô thì trên thực tế cả cái labo tại Việt Nam chúng ta có thể làm được cái EGG và EGM của cả cái tác nhân gây nhiễm trùng bào thai, nhưng mà riêng cái EGG của avidity, cái ái lực EGG thì chúng ta hầu như không làm được. Vậy thì nếu như một trường hợp chúng ta siêu âm, chúng ta thấy thai nhi có khả năng là bị nhiễm trùng dựa trên cả cái dấu hiệu siêu âm, thì chúng ta có cần sàng lọc cái EGG và EGM không? Hay là chúng ta chọc ối và sau đó chúng ta làm cái PCR trong dịch ối luôn? Là câu hỏi thứ nhất. Câu hỏi thứ hai nó cũng liên quan tới cái nhiễm trùng bào thai nhưng nó không liên quan tới bài giảng của cô, thì em xin hỏi thêm. Nó liên quan tới là vi khuẩn giang mai, Treponema. Thế thì chúng ta đang sử dụng cả cái test, đó là cái test VDRA, tức là Venereal Disease Research Laboratory. Vậy một cái test nữa là chúng ta dùng cái TPHA, tức là cái Treponema pallidum hema agglutination assay. Hai cái test này là cái test không đặc hiệu và chúng ta chỉ mang tính chất tầm soát. Ở Việt Nam thì chúng ta không có cái test FTA IBS. Cái test FTA tức là cái test mà fluorescent Treponema antibody absorption ấy. Cái test đấy mình là cái test chẩn đoán chính xác là người mẹ có bị giang mai không. Vậy thì nếu mà ở Việt Nam chúng ta không có cái test chẩn đoán FTA IBS thì chúng ta có sử dụng được cái VDRL và cái TPHA để chúng ta khẳng định là người mẹ đấy bị giang mai và chúng ta điều trị cho người mẹ để tránh các cái nhiễm trùng từ mẹ sang con hay không ạ? Em xin cảm ơn.
Okay. So with the first questions, if you look very precisely at the serology, if you can't get IgG avidity, you can concentrate on the result of the IgG and the IgM to give clue if it's specific or non-specific IgM. For example, in a primary infection, a typical primary infection, as I've shown one example here, you have low IgG, very high IgM, and that's very, very in favor of a recent infection. It's more difficult, the interpretation is more difficult when you have already high IgG and low IgM. That's more difficult. And in those cases, really, IgG avidity helps. But when you have low IgG, high IgM, it's going to be a primary infection. So you can rely on that. And otherwise, of course, you were mentioning the PCR in amniotic fluids that gives the definite diagnosis. And of course, it's very helpful. For the second question on syphilis, I'm afraid I'm absolutely not an expert in syphilis, but because I'm a virologist and I never do the interpretation of syphilis, so I can't help you. I'm sorry. I will say probably something that is not pertinent or some. I'm afraid not answering that.
I think Valentine will cover the syphilis in your talk, so you get the treatment in depth anyway.
Okay.
Cái điều trị như vậy, cái điều trị của Ida trước 16 tuần thôi chứ, đúng không? Để nói.
Mời các anh chị học viên tiếp tục đặt câu hỏi cho hai bài báo cáo của giáo sư McKinley và giáo sư Lauren Marovin ạ.
Alo. Trước khi tiếp tục có các câu hỏi của các anh chị thì nhân cái câu hỏi của bác sĩ Đông thì chúng tôi cũng xin chia sẻ thêm một thông tin nữa, không phải là câu hỏi. Cho đến hiện tại thì tại Việt Nam mình thì chưa biết về cái độ lưu hành của CMV, và như ban nãy bài trình bày của cô ấy thì dựa vào cái sự lưu hành của cái huyết thanh CMV, nó sẽ liên quan trực tiếp đến việc là mình tiên lượng cái nguy cơ nhiễm trùng tiên phát và thứ phát, và từ đó nó sẽ biết được đến cái nguy cơ mà lây sang cho em bé như thế nào. Và trên một cái tinh thần là mình cũng không biết cái tỷ lệ khi mà mẹ bị nhiễm nguyên phát như thế thì cái nguy cơ lây sang cho em bé là như thế nào, và cái biểu hiện lâm sàng của em bé đấy là như thế nào. Việt Nam mình hoàn toàn không có thông tin về đó, và chính vì lẽ đó mà giáo sư Vin và cô Mariana đã hỗ trợ Bệnh viện Phụ sản Hà Nội đã xây dựng một cái đề tài rất lớn có tên là CMV Study, và chúng tôi hy vọng rằng là cái kết quả này sau khoảng 3 năm nữa có kết quả thì gần như sẽ trả lời được tất cả những câu hỏi đó. Nghiên cứu này thì đã được đăng ký trên thử nghiệm lâm sàng trên trang Clinical Trial, bắt đầu lấy mẫu tại Bệnh viện Phụ sản Hà Nội, và chúng tôi làm đúng theo cái quy trình đó là xét nghiệm ngay từ 3 tháng đầu, xét nghiệm trước khi sinh cho bà mẹ và sàng lọc cho toàn bộ 5.000 cặp mẹ con, cũng như là theo dõi dọc tiếp tục 2 năm với những cái trường hợp mà sơ sinh bị nhiễm CMV bẩm sinh. Nhân đây thì chúng tôi cũng giới thiệu với lại tất cả các bác sĩ tham dự khóa học này cũng như là ở tất cả các điểm cầu để có thể là tư vấn cho những cái sản phụ mà trong cái quá trình khám thai có một cái cơ hội tham gia vào một cái nghiên cứu rất lớn và rất là có ý nghĩa như thế này ạ. Hy vọng rằng là 3 năm nữa sẽ có kết quả để báo cáo với lại tất cả các anh chị ạ. Xin chia sẻ thêm thông tin ạ.
Xin cảm ơn hai bài báo cáo của giáo sư Marian Vin và giáo sư Mark TP. Em có một câu hỏi cho giáo sư Mark TP về bài trình bày về chẩn đoán trước sinh của thầy ạ. Thì hiện tại ở Việt Nam, các lab chẩn đoán trước sinh đang đưa cái sàng lọc 9 bệnh gen lặn ở trong máu của người mẹ và người bố và chẩn đoán trước sinh. Thế thì chúng em đã gặp những trường hợp mà gia đình phát hiện đột biến ở cả hai bố mẹ và có nguyện vọng được chẩn đoán trước sinh cho thai. Thế thì ở những cái bệnh như là thalassemia hoặc là POM thì nó rất là rõ ràng là có chỉ định chẩn đoán trước sinh rồi. Tuy nhiên là có những cái bệnh như là rối loạn chuyển hóa đồng, bệnh hội chứng Wilson hoặc là cái G6PD hoặc là cái thiếu men 5 alpha reductase thì đã có những gia đình phát hiện đồng hợp tử đột biến gen trên thai sau khi chọc ối chẩn đoán trước sinh và họ đã xin đình chỉ thai nghén. Đó là những cái trường hợp mà rất là khó xử đối với chúng em. Thế thì em xin hỏi ý kiến của thầy và quốc gia của thầy về vấn đề chẩn đoán trước sinh trên những bệnh gen lặn. Em xin cảm ơn ạ.
I think carrier status screening has been advocated in autosomal recessive disease. This is a new indicated. Some of them it's not in routine practice at the moment. But if you find carrier status positivity in both parents in autosomal recessive cases, then if you embark on that kind of screening test, then the natural clinical way forward for that would be then to either offer pre-implantation genetic diagnosis or prenatal diagnosis. So I think before you even start doing carrier status, you should, be clear in your mind what you're going to do with the results. And if you embark on that screening with the consent to the parents that you will then go on and subsequently look in the baby, well, then you go on and look in the baby. But I think it's important, as in all of these tests, to be clear in your mind, not you specifically, but us as doctors, be clear in our mind about why we're offering these tests before we offer them, and then to counsel clearly the patients so that they understand the implications of the testing going forward.
Mời bác sĩ Trang, Bệnh viện Phụ sản Hà Nội đặt câu hỏi ạ.
Dạ, em xin cảm ơn tiến sĩ Marian về cái bài giảng về huyết thanh và các mắc cơ nhiễm trùng trong thai nhi rất là hay. Em xin có một câu hỏi về một cái trường hợp lâm sàng. Có một thai phụ lần đầu tiên mang thai, tuần thứ bộ khi thai phụ làm xét nghiệm sàng lọc tiền hôn nhân chưa phát hiện có thai thì xét nghiệm IgM rubella, xét nghiệm rubella IgM là rất là ở ngưỡng 2,6. IgG là 170, là IgG cao và IgM ở mức rất ranh giới ạ. Thì sau đấy 2 tuần sản phụ được làm lại xét nghiệm thì IgG 77, IgM 0,1. Thì những trường hợp này thì có thể cho tiến sĩ có thể cho ý kiến về trường hợp này. Như vậy là đến cái tuần thứ 6 thì là xét nghiệm IgM gần như là âm tính rồi. Thì cái thai kỳ này có phải là một thai kỳ rất an toàn, có thể theo dõi thai được hay không ạ? Bởi vì lần đầu tiên lúc 4 tuần IgM là 2,6 là ngưỡng. So với cái giá trị tham chiếu của cái xét nghiệm đấy, dương tính là bé thuộc 0,1, thì 2,6 là dương tính. Sản phụ rất lo lắng. Ở cái thời điểm 4 tuần đấy, sản phụ được tư vấn là bỏ thai. Đấy. Và khi tuần thứ 6 xét nghiệm như thế thì âm tính thì cho em hỏi là thai kỳ này có được gọi là một thai kỳ khỏe mạnh và theo dõi thai tiếp được không ạ? Em cảm ơn ạ.
So if I get it well, it's first serology with low IgG and low IgM, and a second test with high IgG and disparition of the IgM. Is that right? Okay. And it was screening. It was for screening, or it was because the lady had a rash or something? It was
xét nghiệm sàng lọc.
screening test. Yeah. Okay. And was she vaccinated, that lady?
Thai phụ đã được tiêm chủng rồi ạ.
Vaccinated. Yeah. And she had 2 doses of vaccination. It's not, you should not even test for rubella IgG when you've done the vaccination. Okay, because a woman who had 2 doses of vaccination, she's fully protected. So what the recommendation in France is not to test. When you know that the lady has been vaccinated, you don't test for the IgG. And probably the IgM you've been detected with might be IgM post-vaccination. It could be, or non-specific IgM. So no, I would not have. I think she should have kept her pregnancy. But,
Phần hỏi đáp dành cho các giáo sư sẽ còn tiếp tục vào cuối buổi ngày hôm nay. Vì thời gian không còn nhiều, bây giờ là phần thời gian dành cho tea break. Sau phần tea break chúng ta còn 3 bài báo cáo của các giáo sư nữa. Trong thời gian các anh chị thưởng thức tea break, chúng tôi có một đường link để khảo sát đánh giá về khóa đào tạo. Các anh chị tham gia online, chúng tôi sẽ gửi đường link trực tiếp. Các anh chị trên hội trường đề nghị quét QR để trả lời các câu hỏi, để chúng tôi sẽ nhận được các ý kiến đóng góp của anh chị cho các công tác tổ chức các khóa đào tạo tiếp theo ạ. Trân trọng mời các anh chị tham gia. Các anh chị tham gia trong hội trường sẽ quét đường link để tham gia khóa khảo sát. Vâng, thời gian tea break là